Hello and welcome, my dear friends. You're welcome from every place, every country in the world. I'm so happy to have you today, guys, and thank you that you choose to attend the session while you have a holidays today. So what are we going to do in this session and in the upcoming session, the up-to-date? I'll tell you, dear. You know that our team, the RCOG team, we love actually to have a free meeting every now and then with you. Previously, before the month of Ramadan, we had a series of up-to-date. If you have attended this, and if you've not, then you shouldn't miss the recording. We have discussed or reviewed the recent TOG articles, okay, that have been published by the college, trying to make it simple, guys, for you and to be updated. This is not only for the purpose of the exam, it's for your own knowledge, so you be updated and confident doctor. And then for the exam, we're trying to make the job as easy as much as we can. So how to make it? It's article, and sometimes it will be written in a difficult way. Sometimes it can be, exhausting to go through one volume of the magazine and read like one article, 10 pages and all. So we choose today two TOG articles, okay, and the scientific impact paper. So the acute coronary syndrome TOG article, this one is actually first published in May 2023, so it's like 2 months ago. The topic itself is a hot topic, and the review of this TOG article is just, like refresh of your information. So you will find that so many information you already know, okay, and you will find also some new highlighted points that can come in your exam. Okay, so I want you guys, after attending this short session today, that you go through the highlighted, the version of the TOG article, okay, and highlight the important point here, okay, that we will tell you about, because this is will be for exam point of view. Either you are preparing for OSCE exam or you are preparing for written exam, this will be important, okay, because the topic itself is very important. After I finish, inshallah, this one, then Dr. Ahmed will be with you in a discussion for some new trend in surgery, okay, that been published recently also by the Royal College of Obstetricians and Gynaecologists, the robotic surgery in gynecology. So you will find some new trend in using the robotic surgery, and because it's a new scientific impact paper also, so we expect that it will appear in the exam. So both, as I told you, practice and exam-wise are important. Another thing as well, my dear friend, regarding the future sessions from the up-to-date session. This sessions is not from part from the courses that we give, it's part from the public group, okay? So this is for, discussion and updating the obstetrician and gynecologist. So we will try to perform a session, okay, every week. This can be one time by me, one time by Dr. Nada, one time by Dr. Ahmed. And also we would like to invite volunteers who would like to share with us, okay, from doctors, respected doctor from around the world. We invite them to come and, join us in this up-to-date series and discuss the update with the obstetrician, especially younger ones. Okay, so hopefully that you enjoy the session and see what is there in this review of the acute coronary syndrome. Dear friends, why the acute coronary syndrome is very important in your practice nowadays? I'll tell you, the incidence itself of the acute coronary syndrome is rare in pregnancy, okay? It's low incidence. However, it has been noticed recently that there is increased number of maternal deaths because of the myocardial infarction, okay? And it found it's around 1 in 5 of the maternal deaths, it was associated by myocardial ischemia and infarction. So if it happened in pregnancy, and actually they find that the incidence is like 6.2 per 100,000. Okay, as I told you, this is not a very big number, but the mortality rate is range from 5 to 11. Okay, and this is mean that up to 1 in 10 women, maybe, okay, or some, if it is 5, we can say 1 in 20 will die after having acute coronary syndrome. So is acute coronary syndrome is something that can be preventable? Okay, actually, not really. How? I'll tell you. Of course, that we do have risk factors of the acute coronary syndrome that is modifiable, like, for example, smoking, obesity, right? So such risk factors, we can work on them. But some risk factors that especially related to the pregnancy are unavoidable. Like what? They found is that acute coronary syndrome risk that obstetric related, like multiparity, like preeclampsia, eclampsia itself, right? So, oh my God, so that's mean that there is obstetric risk factors, yes, and there is background risk factors, and you need to be aware of both of them. And, you know, some of them are modifiable, some of them are not modifiable. Okay, so if the acute coronary syndrome happened during pregnancy, okay, when likely you think it will happen? Is it in the first trimester, second, third, or after delivery? What do you think, guys? The incidence is higher in which gestational age? Any answer? Third. Yes, very good. Third. Okay, anything else? So the total number of, from the studies, because I told you this is a review, okay, of evidence and literature. So it's 2/3 of the cases occur during pregnancy, 1/3 up to 1/3 occur in postpartum. So 38% found to be antenatal, 21% found in one study, right, and et al. Okay, this is occurred in intrapartum, 41 occurred postnatal. Okay, so this is one study or one review, okay, that we found. Another one found that 2/3 in the antenatal and delivery, 1/3 after delivery. So overall, third trimester, intrapartum, postnatal is the most common, right? Okay, so if it happened near to delivery or in the third trimester, outcome is unfortunately worse than first or second trimester. And as you can see here, that most commonly, unfortunately, this has happened in the third trimester, intrapartum or postnatal. Okay, so for you as an obstetrician, why it's important, okay, to study the acute coronary syndrome? I'll tell you, okay, acute coronary syndrome is now all over the world, the incidence increased. But in pregnancy, okay, we find that it's one of the most important differential diagnoses of acute chest pain, right? And also one of the differential diagnoses of collapse, right? Isn't it? So you need to be aware of what is the acute coronary syndrome. I found this picture, okay, it's very funny, and in the same time, it's very simple. This is from osmosis, okay? So the acute coronary syndrome, it's a can't miss diagnosis, and it's caused by sudden interruption or loss or sudden, cut off of the coronary blood flow, okay, which is known as cardiac ischemia or myocardial ischemia. It is divided into 3. It's either STEMI or non-STEMI or unstable angina. So what is a STEMI? It's ST elevation, myocardial infarction, right? So what happened? Simply, why we do have this type, why we do have the non-STEMI, and why we do have the unstable. The STEMI or ST elevation type is complete acute blockage of the coronary artery. All of a sudden, okay? So sudden shutdown of the coronary artery. And transmural infarction of the wall, this is supplied by the artery. How about what is the non-STEMI? Non-STEMI is the supply and demand mismatch between the supply and the demand, okay? And we can find non-transmural subendocardial infarction. What is the unstable angina? Supply and demand, there is mismatch, okay? There is result in myocardial ischemia, but not to the level of infarction. So infarction did not occur yet, okay? Okay, so for the symptoms, because it's very important for your clinical exam and your understanding of the cases, you need to know that there is typical symptoms and there is atypical symptoms and presentation for the acute coronary syndrome. Typical like what? Anybody can tell me what is the typical presentation of acute coronary syndrome? What do you think, guys? Anything that can remind you with typical presentation? Chest pain, yes, excellent, okay. Chest or epigastric pain that may radiate to the neck or the arm, okay? So this is the typical symptoms. Well done. Okay, so the typical symptoms usually more common in men than women. Okay, so we are obstetrician, we deal with ladies here. Yes, we are. Okay, so acute coronary syndrome can present in women with atypical symptoms, and this is if she's pregnant or non-pregnant, we can find the same. What is the atypical symptoms or presentation? Take care for the EMQ or for the clinical presentation cases. Non-specific pain, nausea, vomiting, and back pain. Maybe also dyspnea, hyperhidrosis, and agitation. Okay, so I can see that most of the atypical symptoms can happen in normal pregnancy, right? Or with other complication of pregnancy, right? So you can find a lady with non-specific pain, nausea, vomiting, sometimes it's gastric pain as well, and back pain. She might have some shortness of breath. Not severe, but she might have something like that. This can happen in pregnancy, right? So that's why it's tricky. How about the clinical examination? So if the symptoms can be non-specific or can be tricky in pregnancy, how about the examination finding? Examination finding, my dear friends, can be unremarkable. You can find nothing, literally nothing, okay, that tell you that this is acute coronary syndrome by examination. Sometimes you can find the change in the vital signs that might indicate hemodynamically instability. So not all the cases are severe, and there is nothing to say that this is a clinical or classic presentation of acute coronary syndrome. It's still differential diagnosis, right? Okay, so here comes the importance of investigation. So investigation here will be your friend that can help you. Like what? What is the first investigation that we do for a case of chest pain? So my champions can help me in that. ECG, yes, well done, yes. We always go to our friend here is the ECG. So what do you expect to find in the ECG? I do expect finding in the ECG that ST elevation. What do you think? not all the cases. Yes, so you can find. Okay, so let's have a look, okay, to what the changes that I can see in the ECG, okay? It can include reduction in the PR interval, sinus tachycardia, left axis deviation, Q wave, and T wave inversion in Witchlet in 2, 3, and AVF, okay? And T wave abnormality in V1 and V3, right? Okay, so this can be a presentation, or can be the ECG changes. Okay, so what else I can find? I'll tell you. And here I'm going to use, my dear friends, okay, the description, the exact word description of the TOG article. Why? Because, you know, it's exam, right? So if we speak about the exam point of view, then I have to stick to the same words of the TOG article, okay? So here, the subgroup of ST elevation myocardial infarction, the STEMI, this is, as we said, referred to the presence of ST elevation or new left bundle branch block, LBB, on the ECG within a clinical context that would fit with the acute coronary syndrome. Okay, so he will give you in the exam, if we speak about the exam point of view, or if we speak about case of clinical presentation, so you have typical or atypical symptoms, chest pain, back pain, radiate, okay, and dyspnea, plus the ECG features of ST elevation or new left bundle branch block. Okay, so this makes diagnosis of what? STEMI, right? Okay, so typically we see chest pain, shortness of breath, or ventricular arrhythmia, okay, and they will be often hemodynamic instability, and time to definitive treatment is a stronger predictor of outcome. Okay, that's why it's very important skill to be able to read or to interpret this ECG. That's why it still comes in the exam, right? Part 1, part 2, sometimes even part 3, okay, ECG, and you will need to diagnose the myocardial infarction or the STEMI. Okay, so what is the national target? National target of the diagnosis say that's 1 hour window between the ECG diagnosis and restoration of the coronary flow. So the cardiac team need to work within 1 hour. So what if happened that you are the first doctor to see the ECG? Means that you need to be able to diagnose on spot. Okay? Okay. How about the non-STEMI elevation? Okay, so like what? The non-ST elevation myocardial infarction. This is typically more stable clinical situation. So the patient will not be so much affected, or you will not see instability. Why? Do you remember? Do you remember this funny picture of the osmosis? Why the patient is more stable in the non-ST elevation MI? Because it wasn't, okay, a sudden block, right? Okay, it was incomplete blockage. Okay, so typically it's more stable clinical situation, well done. And so hemodynamic instability is not uncommon. Risk assessment on individualized basis is crucial to stratify the patient who would benefit from the emergency procedure against the procedure delay, right? What is the ECG changes? I will tell you. ST depression, O and T wave inversion. Okay, so how to diagnose a non-ST elevation MI? ST depression with T wave inversion. Okay, guys? Clear? However, sometimes the ECG can be normal, but remember that cardiac biomarkers will be raised. Okay, unstable angina. This is when there is chest pain or shortness of breath at rest. Okay, sometimes with the ECG changes like the non-STEMI, but without a biomarker rise. Okay, why you will not see in the unstable angina raise in the biomarker? Do you remember from this photo of the explanation? Do you think that infarction occurred yet or not? Yes or not? Infarction occurred or not? Not yet. It's ischemia, but not yet. Okay, so this is what I can see in the ECG. Okay, good. How about the biomarkers? How about the investigations? What do you expect in the investigation? Blood investigation. Would you please tell me? I give you the name of the investigation and you tell me will be helpful in the diagnosis or not. Okay? A brain natriuretic peptide, BNP, or NT-pro, BNP. Will it be helpful in diagnosis of acute coronary syndrome? Okay, so doesn't have a typical rule in the diagnosis of acute coronary syndrome, but it can help. How do you think it can help? Would you please give me another cardiac condition when the BNP is raised? Another cardiac condition that's very important for your exam. Yes, peripartum cardiomyopathy. Well done. Okay, so cardiac failure as well. Okay, so it can help you for the differential diagnosis, right? We said clinical presentation of the acute coronary syndrome and other differential diagnosis of acute chest pain and dyspnea is not typical, right? So one of your differential diagnoses can be pulmonary embolism. One of your differential diagnoses can be MI. One of your differential diagnoses can be peripartum cardiomyopathy, especially if the main problem was shortness of breath, right? So it can help for other differential diagnoses. Okay, how about troponin? Please give me a yes or no. Is it helpful? Yes, helpful. Well done. Okay, I'll give you another sentence and you tell me yes or no. The other sentence says that troponin is the gold standard for diagnosis of acute coronary syndrome. Yes or no? So Dr. Amira, well done. Okay, Dr. Sophia, well done. Dr. Farhan, let me explain. Okay, so the troponin is highly sensitive, but non-specific marker, okay, for any form of myocardial injury. So it can be raised in cases of myocardial injury, but not specifically or exclusively acute coronary syndrome. Like what? Please give me another situation. Yeah, myocarditis, profound hypertension, cardiomyopathy, aortic dissection. Also in some obstetric complication like preeclampsia or cardiac decompensation or autoimmune disease that have cardiac involvement. So it's good, but not the gold standard. Okay. Okay. How about echo? What is the importance of echo in diagnosis of acute coronary syndrome? Echo is diagnostic, or echo can help and rule out other differential diagnosis? Which one you choose? If I said it's diagnostic for acute coronary syndrome, is option A, or it can help in the diagnosis and rule out other differential diagnosis, like, for example, cardiomyopathy, is option B. So which one you will choose? It can help. Yes, good, well done. Okay, so it can help, but not diagnostic. How about the angiography? Cardiac catheterization and angiography. Yes, well done. Can I say it's a gold standard? Yes, I can. Yes, of course. Yes, I can. So it's also very helpful because it can turn into treatment within minutes, right? Okay. So the angioplasty for the emergent assessment of patient with acute coronary syndrome, cardiac catheterization and angiography with a view to proceeding to angioplasty is the gold standard. Okay, this is very attractive sentence for the examiner, okay, to give you a question. So what is the gold standard? Simply cardiac catheterization and angiography. Okay, good. Is it available? Most of the hospitals, they have availability across the UK on 24-hour per day and for 365 days per year. What do you think? So useful tool, right? Okay, so we can achieve the arterial access to direct imaging of the coronaries, okay, in 5 minutes or less than 5 minutes with immediate progression to intervention as needed. That's why it's very good. Can I do it in pregnancy? Can I do angiography in pregnancy? Yes, fetal risk is low, so it can be done, okay, of course, in pregnancy, but radiation to the mother considered to be higher, okay? However, if it is life-threatening conditions, then we have to do it, right? Okay, so how about cardiac CT, my friends? Do you think that we use cardiac CT for the diagnosis in pregnancy? No, maybe in non-pregnant situation, but not in pregnancy. How about cardiac MRI? Is it indicated in emergency for acute coronary syndrome? No. Okay, how about CTPA? Yeah, so it can help for the differential diagnosis. Yes, good. So it's only if you suspect pulmonary embolism, okay, and you don't know the chart, the very famous chart of the pulmonary embolism diagnosis, and based on the X-ray is abnormal, we go to the CTPA, or if it is normal, we go to the VQ scan, right? Yeah, okay. So they give you here some information about the CTPA, which is already repeated information that it gives a fetal exposure of 0.01 to 0.66, okay, mgy, depending on the scanner and protocol, and it carry a small but significant increase in maternal lifetime risk of breast cancer above her background risk, okay, so which is already a previous information that they asked you before in the exam if you relate to this before. Okay, so now, guys, after we discussed the approach to the diagnosis, okay, how about the management now? What do you think? Can you please give me some strategies of management for a case of acute coronary syndrome in pregnancy? First of all, before we enumerate, okay, management strategies, you have to remember, especially if we speak about the part 3 or we speak about the OSCE exam, you have to remember that such cases is not an individualized, case. It is not person management. It's a multidisciplinary team, right? So multidisciplinary team that's include obstetrician, anesthetist, cardiologist, pediatrician, and maybe interventional radiologies as well, right? Okay. If we have availability, okay, of obstetric intensive care or both cardiac and obstetric intensive care, that will be very good, right? Okay, so that's very important, yes, in the management. What else do I need to remember? I need to remember that percutaneous coronary intervention, okay, as it is identified as the gold standard outside pregnancy, okay, for the management, can be used in pregnancy or not. Percutaneous intervention, okay, as you can see here, okay, in this figure, the figure 4. This is RAO caudal of the left coronary system demonstrating revascularized LAD artery, okay, following the percutaneous intervention. In this case, the LAD was stent, okay, to reopen the vessel and seal the dissection flap closed. Okay, so after the catheterization and the stent, this is the result, as you can see, and resume again of the flow. Okay, so is there any risk? Is there anything to take care of in this treatment? Yes, aortic dissection and radiation risk. However, radiation risk to the baby is not severe. Okay, so we will be very careful of the aortic dissection. Okay, so if there is any other therapy that we can use, so the details of the treatment, I'm just, skipping the detail, trying to fix the information that is needed for the discussion now. So the take-home message will be much easier for you guys. How about the thrombolysis? Can I use thrombolysis? It can be used, especially, my dear friends. Okay. Yeah. Especially if there is contraindication or non-availability for the PCI, the percutaneous intervention. Okay, so what is the risk that associated with the thrombolysis therapy? You remember that we have studied some information about the thrombolysis therapy in a stroke in pregnancy. Yes, the risk is the catastrophic bleeding that can occur, right? However, the number needed to harm, okay, is in one analysis was low as 78 with regard to intracranial hemorrhage. The thrombolysis is relatively contraindicated, not absolute. So it's relatively contraindicated in pregnancy because of the risk of maternal bleeding, which mainly arise from the genital tract, okay? Subplacental bleeding, okay, specifically. They have found also when they use the thrombolysis in treatment of pulmonary embolism is a massive one, that thrombolysis is associated with 6% risk of fetal loss and 6% of premature delivery rate. So not only maternal bleeding, there is also 6% loss of fetal loss and 6% of premature delivery rate. Okay. However, the streptokinase, okay, or the recombinant tissue plasminogen activator cross the placenta in significant amount, okay? So you should know that such a treatment will be done only or considered only by the MDT and the hematologist to advise in a place or in a situation when there is no availability of the interventional treatment, the percutaneous intervention, or it's contraindicated. Okay, guys? So it's not one of the things that we can do. PCI is still favored, and PCI is still gold standard. Okay? Okay, so how about other drug treatment? When we speak about use of drugs or medication in pregnancy, dear friends, you need to think about, is it safe to the baby or not? Does it cross the placenta or not, right? So if it crossed the placenta, would it cause harm or not? So how about breastfeeding? Is it crossing the breast milk or not? Excreted in the breast milk or not? Harmful to the baby or not? Okay, so those are the consideration of treatment. So I will give you the treatment, okay, options of treatment, and you tell me, can I use it or not? Okay, in this pregnant lady or breastfeeding. Number one treatment is aspirin. I can use loading dose of aspirin 300 mg, and after that we'll continue with 75 till delivery. What do you think? Yes, okay, well done. How about heparin? Yes, of course, it can be used till the day before the angiography. Okay. So if the angiography is available immediately, then we don't need the heparin now. Okay. Okay. How about antiplatelet clopidogrel? Can I use it? Yes, well done. Okay. What is the precaution of use clopidogrel in pregnancy? Stop 1 week. Yes, yes, well done. Okay, before delivery or before intervention if you have a patient for surgery, for example. Okay, okay, guys. So how about analgesic? Can I use analgesic? Can I use analgesia? You know, in the cases of acute coronary syndrome, usually they use morphia or opiates if the pain is too severe. Yes, okay, yeah, just general precaution of avoid the non-steroidal. Well done, Dr. Sophia. Okay, so how about nitrates? Can I use nitrates in pregnancy? Yes, but there is only, you know, precaution of use that it can cause uterine hypoperfusion, okay? So a very important, okay, to take care of use of the nitrates. How about intropes? Yes, okay. So when a patient had a cardiac problem, my dear friends, so there is some other cardiac medications that can be used, right? Or if she had associated hypertension, so antihypertensive medications that can be used as well. So I'll give you some names and you tell me, shall I use it or not? So ACE, angiotensin converting enzymes. inhibitors. No, no, no. Okay. Not safe during pregnancy, however, it can be used after delivery. Okay, how about the beta blocker? Yes, it can be used. Could you please give me side effects of using beta blocker in pregnancy? Two side effects to the fetus. I think it was exam questions as well. So it can result in or associated with fetal hypoglycemia or growth restriction. Okay, okay. So if we speak about the cardio-selective member of the beta blocker, we find is that the bisoprolol is the one of choice. Which one? So he gave you in the exam, in the options, labetalol for a cardiac patient, not hypertensive, okay? And bisoprolol, which one you will go for? Yes, the bisoprolol. Yes, well done. Okay, how about the angiotensin 2 receptor blockers, ARBs? Not used. Okay, can I use it in breastfeeding? So ACE can be used in breastfeeding, but how about the ARBs or ARNI as well? Angiotensin receptor neprilysin inhibitor. No, not for breastfeeding, okay? So avoid it in post-pregnancy and breastfeeding. Nowadays, your exam, they like asking question on, if we speak about part 1 and part 2, they like to ask questions on medications, okay? In the part 3 exam, for the RCOG guys take care, they will give you a summary of a patient and her medication that she's using, okay? And you need to highlight and comment, okay, on the medication that is not advised during pregnancy or not breastfeeding. If you didn't do so, you will fail safety, okay, for the medication. So please take care which medication to be used during pregnancy safely. If used with precautions, what are the precautions? If it is not advised during pregnancy or not advised in breastfeeding, then don't use it, okay? Okay, as I told you, this is a repeated information already that we know. So now I'll ask you a question, guys. So you can see that this review of the TOG article today is very easy. The furosemide, what do you think? Safe or not safe? Yes, safe in both pregnancy and breastfeeding. Well done. How about the thiazide? Pregnancy, no. Breastfeeding can be used. Okay, how about spironolactone? Not in pregnancy. Pregnancy, no. Breastfeeding, yes, can be used. Okay, how about the statins? No, no, of course, no. Okay, so how about low molecular weight heparin? A woman can continue treatment with low molecular weight heparin while pregnancy, of course, but take care of the bridging and the risk of bleeding, right? Okay, how about warfarin? This is the last drug to ask. Warfarin is not advised during pregnancy because of the teratogenicity effect, but it's safe in the breastfeeding, right? Okay, so dear friends, how about the pre-delivery plan for a woman with acute coronary syndrome in pregnancy? If the delivery not imminent, my dear friends, we all know that we need to wait for several weeks, okay? In the previous TOG article of MI in pregnancy, it was 2 to 3 weeks, okay? But here he just mentioned or comment several weeks, okay? And if this has happened already away from the time of delivery, okay, so advice is to deliver by 40 weeks of gestation, okay, and the mode of delivery will depend mainly on the obstetric factors. Take care of this coming information, okay, again, aside of exam question. Prostaglandin E, like prostein, okay, can I use it in a cardiac patient with coronary syndrome? A patient now, chronic patient, okay? Can I use prostaglandin? I'm not speaking about acute situation, guys, just I'm speaking about now a patient, non-cardiac patient. Prostaglandin E analogs like prostein can be used, but be careful if the woman has severe or unstable cardiac function, not to be used, okay? Okay. How about prostaglandin F, like carboprost? So a woman who had cardiac problem, okay, and she got postpartum hemorrhage. And by the way, postpartum hemorrhage is one of the risk factors of acute coronary syndrome, of course, because of the ischemia and blood loss. So carboprost, no. Carboprost, no. Prostaglandin F analog, okay, avoided. How about ergometrine? Avoided. Vasoconstriction, of course, avoided. Okay, so my dear friends, okay, oxytocin can be used or not? Slow intravenous infusion can be used, okay? Okay, how about the advice of second stage for a woman with coronary, known to have a coronary disease? Will you advise this lady to deliver normally or advise this lady to have a cesarean section? Choice of mode of delivery, this will be for obstetric indication unless it is severely compromised cardiac function, like NEHA class 3 or 4, or the WHO classification, okay, also class 3 or 4. Okay, so dear friends, let's speak about here a patient with a stable condition, more stable condition, okay, but she had a coronary artery disease. The advice here is to allow 2 hours for passive descent. How many hours for passive descent, guys? 2 hours, okay? 2 hours without pushing. Allow 2 hours of passive descent for of the presenting part before commencing active pushing, and this can shorten the duration of pushing. Shortening the active second stage by performing early instrumental delivery is no longer routinely recommended, okay? Guys, be careful. We speak here about cases who are stable, but not NEHA class 3 or 4, or if we speak about the modified WHO classification, also the same. Modified WHO classification, class 3 or 4. Those are the ones that we need to actually advise against pregnancy for them. And if they deliver, we will choose the cesarean section. If they want a vaginal delivery and opted for vaginal delivery, then shortening of the second stage. Okay, so this is the answer of exam question. Yes, this TOG article is, or this review is very recent, okay? But there was a previous studies, okay, that mentioned that 2 hours before the passive descent and not routinely in a stable patient. So a patient who had only history of coronary disease, she's now stable, okay? Let's say she had treatment, she had a stent or whatever, and she's now stable, okay? Do I need to shorten her second stage routinely? Not for everyone. So saying not routinely means not for everyone. That will be according to the patient situation, okay? In case of severe cardiopulmonary shock or cardiac arrest, of course, remember the resuscitation should be done in the left lateral tilt to relieve the aortocaval compression. And if we speak here about 4 minutes passed from the resuscitation without any result, then we go for postmortem cesarean section if the pregnancy is already advanced, right? This is the same information that we already know, nothing new. Here comes a part for counseling and advice for the future pregnancies. My part 3 candidates and OSCE candidates, please take care of this information. For the future pregnancy advices, this woman needs a pre-pregnancy counseling, a pre-conception planning with MDT that include a cardiologist, obstetrician, senior obstetrician, anesthetist, right, and the midwife. The pregnancy will be considered as a high-risk pregnancy because the risk of recurrence of acute coronary syndrome in pregnancy in a woman with history of ischemic heart disease is 9%. So this is, again, can be an attractive area of the examiner, of the exam questions, to ask about the risk of recurrence of acute coronary syndrome in pregnancy. So the number will be 9%. Pre-pregnancy counseling and optimization of cardiac function is essential to improve prognosis and minimize the risk of decompensation during or subsequent pregnancy. Of course, medication review. So remember, MDT medication review. So how about interval between acute coronary event and pregnancy? So a woman got acute coronary event and now she wants to be pregnant. What is the safe interval that you will advise? 3 months after the acute coronary event, 6 months, or 12 months, or 24 months? Would you please choose number? It's 1 year again, so it's 12 months. Well done. Again, those particular area are attractive for the examiners, okay, to ask about. Okay, so again, please, my dear friends, remember the post-delivery, we do always have contraception advice. What is a contraception advice for a woman with acute coronary syndrome or ischemic heart disease? Anybody? What is the method that is absolutely contraindicated? Barrier, Dr. Hana, is not recommended alone due to high failure rate. So it is, yeah, have no complication, no side effects, okay, but not recommended alone. IUCD can have risk of vasectomy. No, vasovagal attack, okay, if it is done in the outpatient. So there is a precaution of intrauterine method that must be done in cardiac patient in hospital, okay, because of the vasovagal collapse secondary to the cervical stimulation at the time of insertion of the IUCD. So be careful if you have a cardiac patient, never to insert IUCD in clinic. Okay, guys? Vasectomy, this is for male, okay? And to advise a male to have vasectomy, that means they must be in a stable relationship, right? So he can do this for her. We speak here, guys, about the contraindicated method, the absolute contraindicated, because I asked this question and I think that you guys have answered another one. The contraindicated method that we will avoid absolutely, it's UKMAC 4, okay, in ischemic heart disease is a combined hormonal contraceptive, okay? All combined hormonal contraceptive that contain estrogen is absolutely contraindicated in ischemic heart disease. Okay, guys? So that's the one that you need to remember to avoid it completely. Barrier method is associated with lower risk of complication, but high failure rate, so not recommended. Progesterone is safe, can be used, okay? Intrauterine method can be used, but with risk of vasovagal collapse. So it must be done in a hospital. Sterilization is not preferable, especially if the woman have severe compromised function, because you know the risk of laparoscopy and the increased pressure inside the abdomen. Okay, so all of this should be avoided actually. So we don't prefer the sterilization. Male sterilization can be a good option if they are in a stable relationship, especially for counseling station in part 3, guys. Okay. Emergency contraception is all okay, no problem. Okay, but again, if you have a patient that requests emergency contraception and she is a cardiac patient, then ICD insertion must be in a hospital. Okay, so intrauterine methods are okay, but only precaution to be in a hospital, or POP are okay. Okay, guys, this is the advice for the contraception. Okay, so by now, my dear friends, we have finished review of this TOG article. Okay, guys. So hopefully that you find it useful. Any questions so far? Alhamdulillah, I'm so happy that you guys find it useful. Alhamdulillah. Okay. Thank you very much. Okay, I'll tell you, Dr. Sofia Dia, our brilliant mentor, Dr. Nada, she is preparing a very nice and very concise infographic for this article, okay? And she is going to share this with you. I'm going also to share my notes on that, okay, on the group, so no problem at all. And in the same time, I will post the original file with the highlighted ones. So if you guys want to go through it once again, you will find it. Okay. So now if you still interested, my dear friend, to continue with us today, this is the time for the robotic surgery with Dr. Ahmed. Yeah. Okay. Okay, so I'll ask you guys for 5 minutes break. Will that be okay? So I'll pause my record and invite Dr. Ahmed to join us. Brilliant presentation. Good luck, Dr. Ahmed. Thank you very much for your time today.
Okay, thank you. Could you please, allow me to share the screen? Thank you.
Sure, sure. Thank you.
Hello, ladies and gentlemen. Hello, can you see me? Can you hear me? Hello, is my voice clear to you? Good, thank you so much. Hello. Right, so hang on 1 second, 1 second, 1 second. Yes, okay. So hello, assalamu alaikum, ladies and gentlemen, my dear friends and colleagues. Welcome to another session from the RCOG. I'm Ahmed, and today I'm going to talk about the robotic surgery in gynecology in line with the latest scientific impact paper that's published by the college a year ago. Well, actually, I think all of you are aware about the conventional laparoscopy, or it is called the CL in this scientific impact paper. If you had a chance to read about it, they call it the CL, which is conventional laparoscopy. Actually, the robotic surgery has been out there for quite a bit of time, I guess maybe 10 years or so. But I guess finally the college, started to, focus, pay a little bit more attention on it in its recent publications. So in robotics, so this is the conventional laparoscopy. I guess we're all practitioners. Is any one of you is not familiar with the conventional laparoscopy? Are there anyone who'd never seen a conventional laparoscopy before? I guess not, right? So this is the conventional laparoscopy, right? It consists of this, they call it the stack system, right? A monitor and the insufflator, the thing that's, used to insufflate the patient with carbon dioxide, and a light source and a camera unit, okay? And this is how it works. This is the very, very, very basic, the baby information. We insufflate the patient with carbon dioxide, we insert a camera with a light source and a bunch of other instruments in order to we'll be able to manipulate or do things, surgical things inside the patient. One thing about the conventional laparoscopy is that you need somebody who works at the cameraman. As you can see there, this is the camera, this is a light source, this is the main surgeon, as you can see, and this guy over there, his only job during the surgery is to hold the camera for the surgeon. So yeah, because you can't actually, we don't have three, it's perfect to work by-handed. So you work from both sides. This is your left-hand side, this is your right-hand side. So you operate on both sides, right? Take stitches, dissect and cut, and somebody else will take care of the camera, right? If this is good or bad? Well, actually, this is not good, because if you have had a chance to work, to do laparoscopy by yourself, you'll struggle, giving instructions to the cameraman to follow you. Sometimes, oh, please, could you please give the camera to the right a little bit for me? Could you please give the camera left to the left for me? Could you please, we need a panoramic view. No, stop a little bit. Could you please zoom in a little bit more? Okay, no, stop. Could you please pull back, please? So all the time you struggle with even with the experienced gynecologist, with experienced laparoscopist, you will struggle, you will waste a lot of time giving instructions and adjusting the camera for you. This is one thing which is not good for laparoscopy, is it? Are you following me, guys? And why are you so quiet? Where are the messages? Good. Okay, so let me just make sure that okay, I got you. Right. Annotate. Where is, yeah, again, that's it. Yeah. So this is about the thing about the cameraman, right? One more thing is the instruments itself, right? They're straight, just like this one. So you can only do two things. You can just rotate and move upward, backward, and to this one, but you cannot control this part, right? You cannot do this wrist movement. You can open it like a scissor or close it, or like cloud thing, like this one. Can you see? You just can open and close, that's it. Or rotate 360 degrees. You can't do anything more than that, which will give you a little bit of restrictive movement, right? So a lot of things that is restricted to the use of this part of the instrument. You follow me? If you had the chance to work in laparoscopy field or to do a laparoscopy by yourself, it is a lot of hassle to do laparoscopic suturing or to operate in a narrow locations, just like the pelvis. This is the problem about the pelvis, about the location we work at. We work at the we are pelvic surgeons. After all, we're pelvic surgeons, aren't we? Yes, we are. The pelvis has a very tough, silly anatomy because it is a narrow space, packed a lot of stuff, and we have this major structures, passing by each other in close proximity. Do you hear me? So you need to be very careful in dissecting things. You need to be very delicate, and you need to be very knowledgeable about the anatomy, right? So you need two things: good knowledge of the anatomy, where's where, and very gentle dissection. Sometimes you cannot do this using conventional laparoscopy. It's very difficult, like in cases of complex gynae surgeries, like in endometriosis or so. Are you following me, guys? Good, thank you. Here comes the robot-assisted laparoscopy. It's not robotics. It's not called robotics. It's not called robotic surgery. It's called robot-assisted laparoscopy. This is as per mentioned in this scientific impact paper, or RAL, robot-assisted laparoscopy. So they separated, as you can see in this diagram, separated the surgeon away from the table, from the patient, from everything. He sits, not standing. He sits in a console, like a gaming console. It's so much fun, by the way. And this console, we have here handles. We have something like controllers, like a PlayStation controllers, right? And something to look, a screen to look into it there, right? The 3D screen. And this is a computer. This console transmits the movement of the surgeon's hands, replicated to these arms. Still not, you didn't figure it yet, right? So again, this is a real picture of what's going on. This is the surgeon sitting, and he's looking into the screen inside the console, and there's something he, holds in his hands, a controller, right? And by moving his hands, the computer replicates his movements into those arms, right? So we have this wrist movement. How it works like this. Okay, this is again one of a live session. As you can see, this time we have two consoles, right? I'm getting to this point later on, but you can see, spot this. Can you see these two consoles? You can see this just two surgeons operating. They're not two surgeons. I'll get to this point later, but you can see those surgeons, right? And so this computer transmits the movement of the hands of the surgeons into those surgical arms. This is the Da Vinci system, or the robot-assisted laparoscopy. Are you following me, guys, or not? Anything difficult? Would you like me to repeat anything so far? Good. So this is, a close picture of the zoomed picture of the console of this called the Da Vinci system. These are the goggles or the binoculars that the surgeon looks into inside it, into a 3D screen. So for the 3D screen, we have the depth perception. If you've ever been to 3D cinema, for example, or you have if you're a rich person and you have a 3D screen in your home, right? So you will, you know what I mean, right? You'll think that you're watching, you have this depth perception that things are, projected into 3D. There's not just, this accent that I know there's something sometimes you can imagine that you can, get your hand inside the screen itself, right? And these are the controllers. So these things, the doctor will put his fingers into those controllers and try to control the arms like this. And also we have these pedals. Can you see? So we have a lot of controllers right there. These are also important for diathermy and for movement of the camera. This is another important thing. There is no cameraman, unlike the conventional laparoscopy. No cameraman person. You're the one who do everything. It is you who do everything. You control the arms, you control the diathermy, you control the camera, everything. You don't have a third arm, but the robot will assist you. Did you get me? Good. Can you see? This picture will show you the controllers. Can you see? These are the controllers. So the doctor, will move these things and the computer replicate his motion, his movement, or her movement to the arms of the robot. Okay, can you see this? Please tell me if the video plays. Can you see the video or not? Can you see it? Is it playing? Good. So can you see this movement? We don't see this in laparoscopy, do we? No, we don't, right? So we have a lot of this, they call it superior flexibility or rest-like movement. Sometimes it's more flexible than the human's wrist or the human's hands, right? So you can move it to the side, to this, to this, to this, right? And by using the controllers, this is how it replicates the movement of the surgeon's hands. Is it clear now? No. Good. So these are, if you saw the picture of these are the traditional conventional laparoscopy. So we got a question, Dr. Safia. So it means that we should know how to operate robot, not surgery, will be done by robots. No, surgery is not done by robots. It's not automated. We are the person. It's just like playing a game, like you're inside your car. You control everything. You're a driver. So if you drive, you can drive your car. Same concept. You can drive the robot. It's not an automated thing. They're developing the artificial intelligence later on, but till this moment, it is you who do everything. You control everything. Did you get me? Okay. So these are very interesting and very expensive, by the way. It's not just very expensive. It's outrageous. No, seriously. It's like 20 times the price of the conventional laparoscopy. So anyway, this is by the way, if you have the chance to read the scientific paper, it keeps saying that the only downside of the robot-assisted laparoscopy (RAL) is the cost. It's too much expensive. All right. So back to the conventional laparoscopy instruments. These are the conventional laparoscopy. Can you see this is it's just like this one, right? By the way, this is the I don't know, this looks like a kitchen grill stick. I got it from the kitchen. I hope to finish this early before my wife figures it out, because she will kick me out of the kitchen. Okay, so it is, you can just have a very restricted movement, as you can see. Compare it to the robotics an instrument. Can you see it's very complex? We have a lot of jaws, we have a lot of articulation, we have a lot of joints. It will allow for this movement, right? For a rest-like movement, in order to do a more fine dissection and precise dissection, precise surgery, right? The suturing laparoscopy, it is very difficult. It's time-consuming. It is, it's a lot of hassle. If you can see, this is the. By the way, this is a video about laparoscopic hysterectomy. I just put it into there. This is the. By the way, this is the infundibulopelvic ligament, and can you see this fine movement of the robotic assisted surgery? Can you see it, right? Can you see the jaw? Can you see the joint movement? Can you see it? You can't do this. You can't do this in conventional laparoscopy. Can you see the fine dissection, right? The fine surgery. It is you who, can you imagine that it's just one person who does all of this, the camera and the two arms. It's magic, right? This is the conventional laparoscopy. Can you see the difference? That there's a big difference between the conventional laparoscopy and the robot. Can you see this is the trying to take a suture, to take a stitch? Can you see there's a lot of steps, a lot of hustle, a lot of trials. You know, you have to hold it in a certain way. You have to use the other hand to hold the needle first. Then, you know, get yourself around the other side of the needle. There's a lot of steps. It will take so much time and very, very, very slow learning curve in order to do a single stitch by laparoscopy. Can you see this, right? This is the difference between stitching in CL and robot. Can you see? Can you see the fast movement and more flexible maneuvers? Can you see it? And this, then they will take the stitch up there and it is done. Looks like somebody is operating from inside the person's body. Amazing, is it? Amazing, is it? Now, can you tell me one question? Which one is, can you see this, can you see this joint, right? Magical, yeah. Which one is much more difficult to learn? Conventional laparoscopy or robot-assisted laparoscopy? Question. If you feel free to open your mic and speak to me, please. Robots is less difficult. Perfect. Conventional laparoscopy, because it's an old technology, and it actually it's not for everyone. It's not just about the risk. It is anything with the more advanced technology actually is much easier to learn. Like for example, the smartphones. If you're old enough, if you back there, like in 2009, 2008, back there before the era of the iPhone, there was a Nokia thing, right? Can you remember the Nokia? Have you ever had a Nokia phone? I got many Nokia phones. I did love it back at that time, but it was difficult, for example, to connect to a Wi-Fi. It wasn't that intuitive, like just these days. You have to have a certain like protocols, many things to do in order to connect to local Wi-Fi. But these days, come on, it's just a piece of cake, isn't it? So same thing, any new technology actually becomes much easier to learn. Okay, so learning curve, this is another point that was stressed many times across the scientific impact paper, right? Learning curve in robot-assisted laparoscopy is much faster than the conventional laparoscopy. So these are the added advantages. Superior dexterity, which means dexterity means this is the ability to do fine things like suturing and these other stuff. Intuitive movement, right? Because when you move like you have like this, the robot also replicate your movement, the same thing, right? So intuitive movement. To the right means to the right, to the left means to the left. There's no reverse or mirror image or those things. And also, can you believe this? Sometimes you got tremors while working, is that correct? So if you hold something in your hands and you got that tremor, right? In laparoscopy. In conventional laparoscopy, you will also have the tremors transmitted to your instrument. Is that correct? But this is not the case in robot-assisted laparoscopy, because the computer will filter your tremors, will not transmit the tremors to the robotic arms. So if you move to the right with the tremors, the robot's hand will just move to the right smoothly, right? Magical. So these are the intuitive movement and filter tremors. This is mentioned in the scientific impact paper. And vision, 3D camera with a depth perception, right? And autonomy of the camera control. Do you know what that means? No, there's no cameraman person. There's some other controls. So when you want to move the camera to the right, you move to the right, you want panoramic view. There's also a keyboard or short keys with a pre-setted orders. So if you want to have a panoramic view, you don't have to move the camera by yourself. Just pressing the button or pressing that handle would move the camera away from you. There's also something called a follow-up camera mode or so. So the camera will follow the tip of your instrument as you go, so it goes with you. A lot of actually advanced technology things. And learning, as I mentioned, fasting learning curve. And we also have this dual console, as I showed you before. Dual console like this, if you've been into a driving school for driving, sometimes, especially in the UK, you see these kind of cars with two pedal system, one for you and one for the mentor or the tutor or the teacher, right? Because you don't want to die and he doesn't want to die too, right? So anytime you do something that's risky, he or she will stop you immediately. Same thing for the dual console thing in robotic assisted laparoscopy, right? So there will be like a trainer and a trainee, right? So he or she will assess you. These are not two surgeons operating. No, it's just one person who's a trainer and the other person who's a trainee. So one person controls the other console. Did you get me? Good. Disadvantages. We have some a bit of disadvantages for the RAL. First and foremost is the higher costs. It's very, very, very expensive, as I've told you. So you need to, if you work in a place that considers the cost benefit analysis, right? So it might be difficult actually to select cases for robotic assisted laparoscopy. Well, they say in the scientific impact paper that where the technology gets cheaper by time, right? So we may expect cheaper technologies maybe in a couple of years. Another disadvantage is eye strain. If you work in a complex gynae operation or complex gynae-onc surgery, you might look into this binoculars inside the consoles, inside the console for maybe 3 or 4 hours, right? So it's difficult. We'll give you the eye strain from prolonged strain. So because we don't find this, in conventional laparoscopy, because the conventional laparoscopy, you're just standing there inside the room and look at everyone, right? But this time you're sitting inside a cabin-like thing, staring into a screen. This will give you an eye strain after maybe a short time. Is it clear? So first, the eye straining. Second is the loss or lack of haptic feedback. What's haptic feedback? Do you know what is haptic feedback? Because you use it every day. No, you don't know. Okay. In conventional laparoscopy, because you're touching the instrument by your hands, right? Like this. So this is the instrument and this is your hand, right? So you'll be able to touch for example, this thing. Okay, so this is hard and this is clicking. Is that correct? So I can see this might be a solid thing inside, right? Maybe a missed IUD or something, right? So, but how did I know? Did I touch it by my own hands? No, I didn't. But there is a touch, a sensation of touch that transmitted from the structure to the instrument to my hands. Is that correct? For example, this is one of my daughter's ball. Okay, so if I touch it by the my instrument, I would know for sure that this is something soft, right? This is, so we do that every day, every operational list. So this is ovarian cyst inside. So you can touch it with the instrument in the conventional laparoscopy. So you will get to know whether it is cystic or solid or so, right? You will lose this haptic feedback in robot-assisted laparoscopy because you're not connected directly to the inside of the woman's body. You're just working inside the console, and there are wires and electricity and a computer transmitting your movement to artificial arms. Did you get me? Is it clear? So eye strain, higher costs, lack of haptic feedback, and also the surgeon operates away from the patient. So sometimes you might be, take a look at the patient's face, for example, to see if there is any pallor, or sometimes there is vital signs, or you need to look at the patient tummy, for example, in order to figure out something or whatever. So it's not that nice actually to work far away from the patient. However, yeah, some people might see it is a benefit. So ergonomics in robotic surgery, we talked about this, so good for the patient, for the doctor. Another problem, it's also there in conventional laparoscopy. It's called the work-related musculoskeletal symptoms, which is basically muscle strain while working, even in cesarean section, even in open surgery. When you stand for quite a bit of time, actually get this back pain. Is it correct? And they say that in this scientific impact paper that we have a greater shoulder and neck muscle fatigue in robot-assisted laparoscopy. This is compared to forearms and fatigue in the conventional laparoscopy. So they're just saying that in conventional laparoscopy, in the older technology, because you're trying to move, you have a lot of input from your muscles in order to try to move the instrument precisely, right? So they have this a lot of work from your forearm muscles. So you have a forearm muscle fatigue after a bit of time, okay? However, this is Dr. Safia. However, in robot-assisted laparoscopy, you have also the muscle pain, but in a different muscle group, which is in the shoulders and the neck muscle fatigue. Because why? Because you're sitting like this, right? And operating. There's no, you can't just do like this. Do you know what I mean? There's no, you can't actually relax. You cannot relax your back. So you're sitting, leaning forward into the console. So you'd have shoulder pain and neck pain. Did you get me? Did you get me, guys? Also, this is added to the previously mentioned finger and eye fatigue compared to the conventional laparoscopy, because you use a lot of fingers trying to move the controllers of the robot-assisted laparoscopy inside the console. So muscle pain, where shoulder and neck, and also eye strain and finger pain. It's not more physical. It's also, the conventional laparoscopy does have a lot of downsides as regards to the physical stress to the surgeon, right? Sometimes after laparoscopy, I need somebody to do some massage to my pad, because actually it's very, very painful, especially if sometimes. I remember that day there was a case of a very, very big dermoid cyst. It took me actually maybe 2 hours in order to get it out from the body. After that, I took the next day off because I couldn't work. I needed rest. I took a lot of muscle relaxant in order to, feel good again. Do you know what I mean? But it was in my forearms, yes, in my pad, because I had to stand for 2 hours. But this is not the case here in robot assisted, because you're sitting, so you never have a back pain. You're sitting in a very, you'll be sitting. We talked about the advantages. I'll get back to this advantages, doctor, in a minute. Okay, and you have an eye strain, right? Finger muscle strain, and shoulder pain and neck pain. Compared to the conventional laparoscopy, you'll have some also muscle pain, but in the forearms, right? In the forearms, especially. Advantages, we talked about that. So back to the advantages, doctor. So you get back to the advantages. Yes, where were we? Yeah, these are the advantages, doctor, over the conventional laparoscopy for the ergonomics, for the vision, for the learning. So severe dexterity, intuitive movements, filtered tremors. For the vision, you have a 3D camera with a depth perception, autonomy of the camera control, and faster learning curve as regards to the learning. So is it clear so far, guys? So tell me, Dr. Safia, the cost of the robot-assisted laparoscopy is, I don't know the exact cost is because it differs from country to country, right? But in the Western communities, it's very, very expensive. It's way more expensive than the country laparoscopy, because can you see the setting itself? You need a separate room, the console, the technology, the arms, the whole system is very expensive, right? And also you need a technician in order to do the regular maintenance to the system. And also you need to train doctors. All of this will cost a lot, is it? Yeah, I will share it. Yeah. I'll pass this file to Dr. Rabba first to verify the information inside it. And she will give it to you. Okay. So far, are you following me? Do you feel that you need anything to be cleared first before moving on? Now the scientific impact paper now discusses, actually there is nothing to mention a lot from there. So we discussed the RAL in complex gynae procedures, first endometriosis, urogynecology, and finally gynaecology. All the time, there's nothing to read, right? All the time, in all 4 sections, the SIP will tells that it is easier, less operative time, less hospital stay, less blood loss, less complication rate. All right, but the articles published regarding the comparison between the robot-assisted laparoscopy and conventional laparoscopy are scarce, right? And the evidence is not that robust. Okay, because why is that? Why is this? Because how many robots? How many centers with the robot-assisted laparoscopy units? Right, not much. Is that correct? And also, yeah, less and less. And also the doctors actually, many of the doctors actually don't know nothing about robotic. You just read about it. Exactly. Same do I. I've never seen a robot in my life. Right? Because it's just there in a highly specialized centers. 2 days ago, I was looking for a robot-assisted laparoscopy training. I found one in Amsterdam, Netherlands. 2 days, just 2 days in non-human situations. And the training will be on models, right? Just gets the cost, 1,500 euros. 1,500 for 2 days, just 2 days, 4 hours a day. It's just eight hours for 1,500 euros on models. This is nothing. It would just give you a little bit of what is you'll actually need a little bit of much more training, not just 2 days, is it? 2 days would not be enough. So regarding this SIP, so they were comparing the robot-assisted laparoscopy to the conventional laparoscopy. First of all, as regards to the complex surgical procedures. So this SIP defined the complex surgical procedure. I found it might be, tempting for an exam question. So what if I told you, what is a complex gynae surgery? So anticipated operative time more than 180 minutes. That's one. So if you think, okay, this patient might take more than 3 hours, we'll be able to perform 2 days. I will get to this point in a minute, Dr. Safia. All right. I'll get to this point because there's a little bit of paragraph in this SIP, talking about the learning and teaching. Just give me 1 minute. So first of all, what is a complex surgery? Well, first of all, the anticipated operative time is 180 minutes. So this is like when you talk to your colleagues before the surgery. Okay, so guys, what do you think about this surgery? Oh, one of you might take maybe more than 3 hours. So now this is a complex surgical procedure. So in the research, in the research context, not in practice, they would refer those patients, if you have the center with the robot-assisted laparoscopy, they will refer those patients with the complex surgical anticipation to the robot-assisted laparoscopy for research, right? For research. There's no guideline or no evidence till day will tell you this patient is better to be operated with robot-assisted laparoscopy. No, there's no such thing yet, because the evidence is not robust, because there's rarity of the robot-assisted laparoscopy centers. So this is one. Operative time more than 180 minutes. Number two, obesity. More than 40 BMI. This is in one paper defined complex surgery as regards to obesity with being the BMI more than 45. This is a morbid obese, right? 45. Moderate or severe endometriosis according to the American classification. Deep pelvic procedures. This could be the deep infiltrating pelvic endometriosis, like nodules in the rectal vaginal septum or the vaginal septum, for example, or pelvic floor muscle repair, like the purge procedure, right? Or the MMK procedure, for example, or the mesh repair procedure. Large uterus weighing more than 700 grams. For any of you who've ever assisted in laparoscopic hysterectomy, I tell you something very important about laparoscopic hysterectomy. One of the most important things that would determine the surgical complexity in laparoscopic hysterectomy is not just the adhesion. Adhesions, you can get over it. one important thing is, especially in low resources, would be the size of the uterus. So in a training situation, we had a lot of training in my department on laparoscopic hysterectomy. We would select, so we would invite, pioneer surgeons from across the country in Egypt, invite them to come to the department, and we select some patients for training. When we selected the patient, we would select patients with small uterus or average size uterus, because big uterus would be difficult, because how are you going to deliver it? Tell me, we don't have the morcellator. So you have two ways, either to cut it into multiple small parts, which will take a lot of time. So no point of doing laparoscopy, because you do laparoscopy in order to reduce the operative time, right? If you take a lot of time cutting the uterus into pieces and get it one piece at a time, so why do this in the first place? So open the patient, go for open surgery, because it will take a lot of time, right? So when we're doing this, we select a very small uterus, because you need to deliver it vaginally. So you will cut through the vaginal vault, right? Deliver the uterus rapidly, right? Then push back this manipulator in order to make the insufflator work again, and you have this nice new peritoneum again, because once you get the uterus out, the vagina will be open to the exterior, right? So all the gas inside the tummy will go out. So we need to rapidly get the uterus out, push back the manipulator, all right, in order to seal the patient from down below. The insufflator will work again, so you get this new peritoneum, so you can continue your operation. If you have a large uterus, you can't do this quickly. So it will take a lot of time, and you will consume a lot of gas. All the time you'll run out of new peritoneum, and you need to wait again for the patient, for the gas to accumulate inside the tummy, inside the abdomen. But with robot-assisted laparoscopy, everything is rapid, everything is fast. There's an arm with a morcellator. Morcellator means this thing that will cut the tissue into pieces, like the mensa in your kitchen, right? With a grinder in your kitchen. So it will grind the tissue rapidly and swallow. Or even if you do it from down below, you can cut everything, even if you want to cut it piece by piece. If you don't have this arm with the morcellator, you can cut everything piece by piece. But in robot-assisted laparoscopy, you can do everything faster and quicker, right? So you will, even if you cut into pieces, you will get it done with in no time. Did you get me? So this is as regards to the size of the uterus. Wide lower trans segment and large posterior wall fibroid. This is one of the worst cases of myomectomy ever. When you have a posterior, especially lower segment myoma, it's near to the major structures first. It is down there in the cervix. It can end up to hysterectomy because you have the uterines on your sides. So if you don't know what you're doing, the patient will come to you seeking for fertility, and she's infertile because of this large lower segment posterior wall myoma. If you don't know what you're doing, right, you will end up with hysterectomy in a patient seeking for fertility. In robot-assisted laparoscopy, because of the fine dissection and the precise movement of the surgical instruments, you can achieve the surgical complexity with much, much greater safety. Did you get it? So these are, again, I know I took a lot of time actually explaining about this complexity, again, in a nutshell, to wrap up. So surgical complexity that's in some papers, not in evidence, is better for robot-assisted laparoscopy of the anticipated surgical time, more than 118 minutes, obesity, more than 45, PMI, moderate or severe endometriosis, deep pelvic endometriosis, large uterus, don't forget, more than 700 grams, wide lower transsegment, and large posterior wall myoma, right? Obesity, why obesity is so much thing? Well, first of all, it complicates the procedure, especially in the pelvis. As I told you, the pelvis is something like this. It's narrow with a lot of structures. With the obesity, you have deep pelvis, so you need a very long instruments. The space will be much tighter. To get it, this is one thing. So this is why the robot-assisted laparoscopy is especially perfect in cases of obesity. First of all, this is very important. Focus, guys, is because you never see this in a conventional laparoscopy. This is one of the key important differences between conventional laparoscopy and RAL, that you can operate, we can perform the procedure under ultra low pressure setting, 6 millimercury. Can you tell me what is the optimum pressure during laparoscopy from the that old practice bulletin published by the college, practice guideline? Yeah, 15. For the entry, it's 20 to 25. For the operating, it's 15 to 18, as much as I remember. In this case, in obesity, you can do it as low as 6 millimeter mercury. So why is pressure so important for the obese patients? Can you tell me why? Why is it so important for the obese patients? Why pressure? Just one word, guys, please. Why pressure is so important? Could guys, please, don't be so quiet. Tell me something. Better view or better view. No, I mean, why obesity? Why pressure? Pressure, this is low pressure. Why pressure? Why the extra pressure is not good in obese patients? Yeah, perfect, Dr. Amira. Respiratory morbidity. In laparoscopy, right? If this is the patient, you need to do this Trendelenburg position. Is that correct? In order to give you all the bowel, the intestine back there, so you can have a clear view of the pelvis. Is that correct? But this is not just a regular patient. We have a big mountain of fat there. And you do this Trendelenburg, so this pressure, right? Fat, the obesity, will compress on the lungs and hearts, right? And you add a lot of pressure inside also, still there's a pressure of the pneumoperitoneum. So you need to try to increase the pressure inside the abdomen. So we have two sources of pressure, the obesity and the carbon dioxide from the insufflator. So every time, even if you work in the laparoscopy setting, you will often hear the anesthetist tell the doctor, could you please lower the pressure a little bit, because we have a high, the bicarbonatogram on the screen tells that there is a high CO2 pressure. Could you please lower the pressure a little bit? If you do this in conventional laparoscopy, you'll not be able to, or the scene, the view will be very difficult to operate. This is why a lot of obese patients will have a higher conversion rate into open laparoscopy. Well, this is not the case for robots. In robot, you can do complex surgical procedures under ultra low pressure, as low as 6 millimeter mercury, which is basically nothing. So good, is it? Wow, this is perfect. You have an obese patient, she might be got a COPD, or sometimes she got some heart problems. Okay, so you can do the procedure under ultra low pressure procedure. So RAL, which is robotic-assisted laparoscopy, has a better surgical outcome, outcomes in obese patients when compared to conventional laparoscopy and laparotomy. This is in a big meta-analysis. So it's better surgical outcome compared to both in obese patients. So we're talking about obese patients when compared to the conventional laparoscopy and laparotomy. Shorter hospital stay, reduced blood loss, less conversion to laparotomy rate, which is a very important surgical outcome to report. Less overall complications. But the thing is, in this meta-analysis, again, and for the 100th time, it's much more expensive. So, did you get the idea about the pressure? I think it's clear now, isn't it? Shall we continue? This is for your Dr. Sophia again, yeah. It's mentioned in the guideline in this SIP that the robot is not for the beginners. So you cannot start your surgical career doing robot-assisted laparoscopy. If you've never done hysterectomy in your life, it's not advised, it's not recommended to do for the first time using a robot, right? If you've never done mesh repair or something like that, at least you should do it at least laparoscopy, conventional laparoscopy, right? So it's not for the beginners, it's for the trained surgeons. Did you get me, right? So this is a copy from this scientific impact paper. The robot-assisted laparoscopy technology is an advanced surgical tool that's not designed to teach surgeon how to perform the surgical procedures. Did you get it? Right? So I think this is why in a training program, if you got into a robot-assisted laparoscopy training, they would ask you first the prerequisites. Do you know what prerequisites are? The prerequisites that you should have a level of expertise, surgical expertise in doing gynae operations. So it's an attitude. You know why? Even in conventional laparoscopy, because you still have a chance for conversion into open laparotomy. So you've never done an open hysterectomy in your life, and now in a situation that you must do it, you will stop, because this is the last resort. If you can't do it in robots, you can do it. You should have another option. You can do it in laparoscopy or open. But if you can't do it, if you can't do hysterectomy in open surgery, there is no other option, right? So it's not for the beginners. For the endometriosis, the disease that actually, that baffled a lot of scientists. Do you know this picture is? This is a conventional laparoscopy. This switch actually is a method to, when you need something to assist you to move the uterus, you can take a stitch through the skin using the conventional laparoscopy to the ovaries or to the uterus in order to it works like a retractor to move things away from you using stitches. And can you see this? This is the uterus. This is the anterior. These are what is this? This is the deep pelvic uterus. This is the very big endometriotic spot between the uterus and what is this, guys? Can you tell me? What is this? Quickly, please. What is this structure? Hello, where did you go? Yeah, the bladder. Dr. Abida, please stay with me for a second. Okay, so what would you do if you have a non-precise instrument, an instrument that does not allow a fine dissection inside there? What would happen to the bladder? Yeah, like the next person. See, focus like this. Same patient. Can you see? What is this? This is the balloon of the urinary bladder. So yeah, and this is the urethra from inside. Yeah, this is the internal urethra meatus from inside. So which is what a such big damage to the bladder, right? But having so this is why the pelvic endometriosis is challenging, because the you need something to be very fine and precise, because you need to have a higher ability to negotiate the tissue. What does it mean by negotiating the tissue? To the fine handling the tissue. So while dissecting, you will figure out, is it dissectable or not, or very adhesive or not, or if I imposed a little bit more pressure down there, will I damage the tissue? No, this is called the negotiation. Or when I pull this thing, will it damage the bladder or not? Or will it dissect or not, right? So this is the where the robot-assisted laparoscopy comes into play. So it has a higher ability to negotiate the tissue because of the fine movement and perform the dissection safely. Okay. Again, this is mentioned in this scientific impact paper because why is this important? Because in the past, they used to cautery everything. They used to electrosurgery, because they need to get rid of this dissection problems. Because the more you dissect, the more you inflict harm and damage to the neighboring tissues. So how to avoid this? Using a highly advanced electrosurgery, which proved actually to be no more safe and also damages the ovarian reserve. As mentioned in the NICE guideline, endometriosis, the best way to deal with endometrioma is excision, not ablation, right? So excision in conventional laparoscopy is not good. As I showed you in this picture, it's challenging because the less ability to negotiate the tissue, right? And it doesn't have that ability to dissect safely because it doesn't have this fine and superior flexibility movement, dexterity. Right, so the better for pain relief, this is as regards to excision. Excision is much better for pain relief when compared to ablation. And for excision, it's better to use a robot-assisted laparoscopy than using conventional laparoscopy. It would be the major technique for DIE. So they actually summarize a lot of papers published and meta-analysis in RCTs. Which one is better, excision or ablation? And this SIP mentions that excision will be the standard technique for DIE in the future. Right? Excision will be the standard technique. There will be maybe recently, the next few years, they will come up with a recommendation that treating DIE is excision, not ablation, right? And robot-assisted laparoscopy is an enabling tool in excision because of safe dissection and excision accuracy. You have the 3D camera with depth perception and magnifying lenses, by the way. And precise for the fine movement, you can, the computer will replicate even the fine movements of your fingers to the working element. So you can focus on the lesion and you can do excision with a nervous pairing. What is nervous pairing? What's the there's not much to explain here, doctor. It's just that you can do it under ultra low pressure. It has the ability, so you can, in the settings, you can set the target as low target pressure, as low as 6 millimeter mercury. Because with the added tools of the robots, it will assist you to do this operation under this kind of pressure. First of all, for example, you have a very good control of the camera, so you don't have a cameraman, first of all. Trendelenburg position, and you have many, many arms. It's just not 2 arms. You have many, many arms. You can first move 2 arms right there to move the organs away and fix them, right? Then another 2 arms, you will do the operation inside the pelvis. Did you get me? Looking back to this early picture, can you see how many arms there? You can control all of them at the same time. Did you get me? So you can select those 2 arms from inside the computer, right? And move those arms away and fix them. Then another 2 arms, you will do the operation. Select another 2 arms, do the operation. Did you get me? And also you can control the camera. This is all done by one person. Did you get it? Yeah, this is important, guys, because why excision is better for the pain relief, not ablation, and why robot-assisted laparoscopy will have less postoperative pain as compared to the conventional laparoscopy. Why? Because of we have something called nerve sparing. There's something called nerve sparing hysterectomy, a nerve sparing trachelectomy, a nerve sparing radical hysterectomy, for example. This is when you identify the neurovascular, the hypogastric nerves during the surgery, which lies in the flap of the peritoneum around the uterosacral ligament. So if you want to spare the nerves while doing surgery, you need to identify those flaps first, dissect them away, not cut them, and move away with your surgery. You can only do this maybe during open surgery, okay, or using robot-assisted laparoscopy. So these are the flaps here. This is the uterus anteriorly. This is the pouch of Douglas down there, and this is the uterosacral ligament. And these are the hypogastric nerves. Of course, they're not visible. You identify them anatomically. That's it. So you need to dissect those first, or using the robot-assisted laparoscopy, you can just, using the precise movement of your fingers that's, transmitted to the robot arms, you can just cherry pick this endometriotic nodule away without damaging the vessels. This is much better than because ablation will be collateral damage, and excision using conventional laparoscopy, it doesn't have this precise movement, so you can damage the nerves around you. Did you get me? So again, why robot-assisted laparoscopy is very good in excision? Because it can do things safely because of the precise movements of the tools, accuracy because of the 3D camera, and precision will enable you to focus on the lesion and do the nerve sparing procedures. Did you get it, guys? Great, good. As compared to conventional laparoscopy, so these are some numbers. I thought they might be, I don't know, important to know. We already have a lot on our plate as regards to the numbers, but the conventional laparoscopy complications in endometriosis and overall are 6 to 7%. I know it's different from the TOG article, but this is how it is mentioned in the SIP. Half of them, 6 to 7% overall complications in the endometriosis surgery. Half of them are bowel injury, right? The robot-assisted laparoscopy complication in endometriosis is half of that number, 3%, right? The more complex the surgery is, the more effective the robot-assisted laparoscopy is, in skilled hands, of course, right? So the more we have complex surgery, the more this number of the complications will increase. But for the robot-assisted laparoscopy, it will not increase a lot. Did you get it? So they said that as a general recommendation. So robot-assisted laparoscopy is as good as conventional laparoscopy, at least, with fewer complications regarding endometriosis. In urogynecology, so tell me, guys, what can you do with robot-assisted laparoscopy in pelvic organ prolapse and urogynecology? What kind of operation it can do, that can be done? Tell me. Mesh operation, the TOG and TVT, yes, it can be done using robot. What else? You can do actually pretty much everything. Sacrocolpopexy, sacral hysteropexy. You can do colp suspension, PERSH, and MMK. It is a very difficult operation, and it's much, much easier to do it with laparoscopy than open surgery, because the space, you'll work in the retial space, the retropubic space. It's a very narrow space. There's a lot of blood there, right? And you need to take stitches, 1 finger breadth lateral to the urethra in a very narrow space, and stitch it to the Cooper's ligament if you're doing the PERSH operation, or stitch it to the periosteum of the pubic bone if you're doing the MMK, which is the Marchetti-Kranz operation. In open surgery, you'll find yourself working in, like, do you know the opening of the scope? This is your surgical field. Everything is just inside there. So it's difficult. Using laparoscopy, it will be good, okay? But using something as precise as the RAL would be magical, fantastic, right? So I've seen a lot of operations on YouTube, by the way. If you just type in RAL in urogynecology, most of the videos will come up as the colpus suspension, the PERSH and MMK. With regular fistula also can be done. You can do pretty much everything, mesh operations, right? And it says in this SIP, in the scientific impact paper, that compared to the conventional laparoscopy and open surgery, the sacrocolpopexy specifically will have improved using, if you do it using robot-assisted laparoscopy, improved voiding symptoms, right? Improved sexual function, less side effects, and shorter learning curve again, but again, much more expensive. This is the repeated information in every page, right? So same thing, improved symptoms, less side effects, much more expensive and less learning curve. Okay, in gynecology, this is the last section for today. So conventional laparoscopy is much better than open surgery, right? So laparoscopy compared to open surgery is much better. And in the UK, by the way, it's the standard procedure in stage 1A endometrial cancer. So we're talking about endometrial cancer is total laparoscopic hysterectomy. They do it in gynae-onc unit, not a center, in a smaller place. They would do total laparoscopic hysterectomy, and that's it, without pelvic lymph node dissection, I guess, because the risk of lymph node involvement, I think it was less than 1%. Please correct me if I'm wrong, but I guess the numbers, the risk of lymph node involvement in stage 1A low-grade endometrial cancer, endometrioid type, is less than 1%. Anyway, it's not our topic today. They would do it in many centers there, in many units there. They would do total laparoscopic hysterectomy, and that's it, right? So it's much more better. It's much better than the open surgery because, again, repeated information in all procedures, where when you compare CL to open surgery, or when you compare RAL to CL, shorter hospital stay, reduced blood loss, fewer overall complication, and some reports would say improved survival, but it's not that good evidence. And also there'll be challenge to obesity and comorbidities. When you talk, this is when you compare laparoscopy, the conventional laparoscopy, to the open surgery. When you compare the new technology, robots assisted laparoscopy, to CL, we have much even better, achieves better operative outcomes, lower rates of conversion to open surgery as compared to this conventional laparoscopy, much more reduced blood loss, better in obese patients, again, because of the ultra low pressure and quicker operative time, shorter operative time. Did you get me, guys? Right? So conventional laparoscopy is better than open, and robot-assisted laparoscopy is better than the conventional laparoscopy in the same operative outcomes: shorter hospital stay, shorter operative time, reduced overall complications. And our robot specifically is better in obese patients because of quicker shorter operative time and the ability to work in ultra low pressure. Right? Cervical cancer, which is one of the most difficult procedure ever in gynaecology because of, tell me, why is it difficult, guys? Again, because of the location of the cervix. The cervix is the lowermost part of the uterus. It's down there, impeded, down there in the narrow cavity, narrow part of the cavity. So it's down there, right? Where down there inside the cavity. It's not all operations, doctor. Sometimes it is used trend and position, sometimes not. And I'm not quite sure about this information, Dr. Sajida, because it's not written there in the scientific impact paper. I don't know what the college thinks about it, but I've seen robot surgery in normal position, and I've seen robot surgeries in Trendelenburg position. So let me make sure about it and come back to you. Will that be okay? Welcome. So it overcomes the narrow relations of the cervix and close proximity of the ureters, right? Because you're down there, you have this cervical peak, cervical mass down there, it's impeded. So sometimes the ureters would be like a distorted anatomy. You don't know what is going near there, whereas where. You know, I remember that like 40 years ago, I was doing hysterectomy, and traditional open hysterectomy with a big fibroid, cervical fibroid. I found we were clamping and cutting the things from up there down there, and I was clamping. We were clamping the part of the broad ligament of the uterus, and I was about to start cutting with the scissor, right? Then I figured out there's something structure. I was there, like in the just next to the fundus or just below the fundus, with a big cervical fibroid. So I was up there. I wasn't down there in the depth of the pelvis, right? Stay with me. I figured out there was like a cord-like structure coming from back in the pelvis to the inside of the clamp. It was the ureter. With a distorted anatomy, this big fibroid thing was pushing the ureter upwards, but it was very, very high. The ureter was just below the tubes, right? It was just there, just below the fundus. I was shocked. We were shocked back at that time. Did you get me? We were about to cut the ureter in a simple hysterectomy patient. So, cervical cancer, things are much, much more complex. So you need something will allow you. And, the problem is when you work in another place, if you're doing surgery, let me tell you, if you have ever did an open hysterectomy before, which part is the most difficult part in doing hysterectomy? Is it when you do clamping of the round ligament, or clamping of the suspensory ligaments, or you do clamping of the ureters and the McEnroe ligament? Which one is the most difficult? Hello, where did you go? McEnroe, why, Dr. Amira? Why is this? Which one's, I'm not talking about the bleeding and the risk to the patient. I'm just talking about the surgical complexity, the ability, narrow space. Yeah, perfect. Narrow space, it's down there, especially if you have a obese patient with a very narrow pelvis. Things you need to, you don't know, the clamps are obstructing you from the view or obstructing you from taking the stitches. But if you have, because your hands are big, and if you have also, if you do it using conventional laparoscopy, it's difficult because the limited motion or mobility of the instruments. This is why they invented the harmonic ACE and the ligature and these things, because you get things done easily, because you don't have to take stitches or using multiple instruments to dissect. You have this harmonic ACE to dissection quickly. On the uterine arteries, you just apply the ligature thing, which is advanced bipolar technology. You cut through the uterine arteries and that's you're done. You're done. And still you have a risk of hurting the ureters. But when you have a robot-assisted laparoscopy, you have two tiny hands with fingers with very complex mobility operating inside a very narrow space, which is better. So this is why it's promising. It's still, as regards to the cervical cancer specifically, I'll get to this moment in a minute. Still, the use of robot is still under research, this part particularly. Well, in research, it said that it overcomes the narrow relations of the cervix and the close proximity to the ureters. And it also, as repeated information, it has fewer complications. And what's this? It's mentioned in the SIP. This is the European Society of Gynaecology. In their guidelines, they recommended that I'm just quoting this. These are not my words. I didn't, do any editing to these words. I just copied these words into this presentation. Open surgery as the standard for all gynaecology, and robot-assisted laparoscopy should be done only in a selected subgroup of women in a specialized centers. So still, if somebody asks you, what is the standard procedure for all gynaecology things? You would say it is open surgery. Wide view, you have multiple surgeons from different, disciplines. If you want to go, you want to extend your incision, you want to do, you want to palpate the liver, you want to palpate the spleen, you want to take an infracolic omentectomy, for example, all these things. If you have any spaces that you want to work in it, you best do this in open surgery, right? But for robot-assisted laparoscopy, it could be done only in a selected subgroup of women in a specialized centers. Okay, and the last slide of today, this is a screenshot from this SIP saying that the NICE guidelines, or the National Institute for Health and Care Excellence guidance on minimally invasive radical hysterectomy, which is done mainly for cervical cancer, recommends the evidence of efficacy for tumors. We were talking about cervical cancer. So tumors here means cervical cancer tumors. Smaller than 2 centimeters is inconclusive for disease-free survival and overall survival compared to open surgery. What's going on? What does this has to do with what we're saying here? Because the NICE were trying to summarize the evidence, and they found that they were comparing disease-free survival, and they had a cutoff of 2 centimeters. So they were comparing women with cervical cancer of less than 2 centimeters to those with more than 2 centimeters, according to the disease-free survival and overall survival. But the NICE actually argued that this cutoff, this 2 centimeter, has nothing to do with the overall survival, because you might have a micro-invasion, for example, less than 5 millimeters, and still you have a low survival rate, for example. So this is not a thing to compare like this. They recommended that robot-assisted laparoscopy in these patients should be performed in the context of research. That's it. Still on the research, right? Okay. We're done, guys. This is all I need to tell you today, and I will still need to look for this Trendenberg position in robot-assisted laparoscopy for Dr. Sajida. Okay, I promise I will do it today for you. As I've told you, I've seen it in both positions, right? So give me just a few hours, I'll get back to you. So do you have any questions so far, guys? This scientific input paper, actually, there's very little information in it. It's loaded with a lot of like research summaries. So if you have the chance to read it, you'll figure out there is not much information you can get from it. So as a final opinion from this SIP, they said that you're welcome to the Sajida. They said that it has, as again, expensive, but it has less operative, shorter operative time, less operative stay. It might improve the survival, but the evidence is weak, less overall complications, and is very expensive, and shorter learning curve. That's it. So guys, thank you so much for listening to me, and hope to see you again soon. Thank you so much. All the best.